What ASCUS actually means. ASCUS stands for atypical squamous cells of undetermined significance. It is used when squamous cells show genuine cytologic atypia that is more than we would accept as benign or reactive, but the abnormalities are still insufficient for a definitive diagnosis of LSIL. The easiest way to position ASCUS is between reactive change and LSIL. Reactive or NIL met ASCUS, LSIL. This represents a diagnostic threshold, not a biological sequence of progression. A patient does not necessarily progress from reactive change to ASCUS and then to LSIL. ASCUS should therefore not be interpreted as a mild lesion, early dysplasia, HPV infection, or SIN1. ASCUS is a cytologic interpretation. CIN is a histologic diagnosis, and HPV positivity is a molecular result. Most importantly, ASCUS is a gray zone diagnosis, but it is not a wastebasket diagnosis. There must be genuine squamous nuclear atypia that exceeds a confident reactive interpretation while remaining below the threshold required for LSIL. Core cytomorphology of ASCUS. ASCUS most commonly involves mature superficial or intermediate squamous cells and mature squamous metaplastic cells. Because these cells normally contain abundant cytoplasm, nuclear enlargement usually produces only a slight increase in the nuclear to cytoplasmic ratio. The classic nuclear size benchmark is approximately 2.5 to 3 times the area of a normal intermediate squamous cell nucleus. However, this should be used as an internal comparison rather than a rigid diagnostic cutoff. Nuclear enlargement by itself is not sufficient for ASCUS. The nuclear contour is usually smooth to only slightly irregular. Chromatin generally remains fine and relatively evenly distributed, although minimal hyperchromasia or subtle chromatin irregularity may be present. Prominent nucleoli are not typical of classic ASCUS and, in the appropriate setting, favor a reactive or reparative process. Cytoplasmic changes may occasionally suggest HPV effect. Perinuclear clearing may be incomplete or poorly developed, and binucleation may occur. Neither finding is diagnostic by itself. Interpretation therefore depends on the combined morphology of the cell. Its maturation, nuclear enlargement, N:/C ratio, nuclear contour, chromatin, and cytoplasmic changes. Whenever possible, compare the questionable cell directly with a normal intermediate squamous cell in the same preparation. The diagnostic threshold. Reactive change, ASCUS, LSIL. The central challenge is deciding whether the nuclear abnormality can still be explained by a benign or reactive process. Reactive squamous cells may show considerable nuclear enlargement, particularly in inflammation or repair. However, they usually retain relatively smooth nuclear contours and fine, evenly distributed chromatin, often with abundant cytoplasm. Prominent nucleoli in an appropriate reparative setting also favor reactive change. The practical question is, can the entire nuclear abnormality be comfortably explained by the benign context? If yes, favor a benign or reactive interpretation. If not, determine whether the abnormalities fulfill the criteria for LSIL. ASCUS occupies the interval between these conclusions. The atypia is real enough that a benign interpretation is no longer satisfactory, but it is not sufficiently developed or convincing for LSIL. This is why ASCUS cannot be reduced to a single measurement. A 2 to 3-fold enlarged nucleus may still be benign if its membrane remains smooth and its chromatin remains fine. Conversely, subtle enlargement becomes more significant when accompanied by genuine contour or chromatin abnormality. ASCUS versus LSIL. The most important epithelial differential for ASCUS is LSIL. In ASCUS, nuclear enlargement is usually mild. The N:/C ratio is only slightly increased. Hyperchromasia is minimal or variable, and the nuclear contour may be smooth to mildly irregular. In LSIL, nuclear enlargement is generally more conspicuous, with convincing hyperchromasia, definite nuclear membrane irregularity, and more clearly abnormal chromatin. Koilocytic change must also be interpreted carefully. A perinuclear halo alone is not a koilocyte. Perinuclear clearing may occur in reactive or degenerative cells and may also be incomplete or equivocal in ASCUS. A convincing LSIL interpretation requires appropriate accompanying nuclear atypia. The nuclear abnormalities are more diagnostically important than the halo itself. Similarly, binucleation may support HPV-associated change in the correct morphologic context, but binucleation alone does not establish LSIL. If cells suggest a low-grade HPV-associated lesion, but the abnormalities remain incomplete, subtle, or insufficiently convincing, ASCUS may be appropriate. Once the nuclear atypia unequivocally fulfills low-grade criteria, the diagnosis should be LSIL rather than ASCUS. Major benign mimics. Several benign processes can resemble ASCUS. The most important are inflammation, repair, atrophy, and degeneration or preparation artifact. Inflammation may cause nuclear enlargement, binucleation, cytoplasmic vacuolation, and degenerative hyperchromasia. A reactive interpretation is favored when the nuclei remain relatively smooth, the chromatin is fine and evenly distributed, and the changes are compatible with the inflammatory background. Infection or inflammation does not, however, exclude ASCUS if genuine epithelial atypia is independently present. Repair may produce striking nuclear enlargement, but reparative cells typically have abundant cytoplasm, relatively uniform nuclei, smooth nuclear membranes, fine chromatin, and often prominent nucleoli. Atrophy is particularly important because benign parabasal cells naturally have relatively high NC ratio. They are usually small and form a relatively uniform population. Their chromatin may be fine or degenerative and smudged, and the background may contain inflammation and debris. Cell type and maturation must therefore be established before interpreting the N:/C ratio. Finally, degeneration, air drying, and fixation artifact can darken or distort nuclei and create pseudoatypia. Artifact-related abnormalities follow poor preservation rather than a coherent dysplastic nuclear pattern. ASCUS versus ASC-H. ASCUS must also be distinguished from ASC-H. Atypical squamous cells cannot exclude HSIL. These categories represent uncertainty around different diagnostic thresholds. ASCUS lies near the LSIL threshold, whereas ASC-H lies near the HSIL threshold. They are not consecutive grades in a biological progression. ASCUS usually involves mature squamous or mature metaplastic cells with relatively abundant cytoplasm and only a mild increase in N:/C ratio. ASC-H more often involves small immature or metaplastic type cells with scant cytoplasm and a substantially increased N:/C ratio, producing concern for an underlying high-grade lesion. The practical question is different for each category. With ASCUS, is this truly LSIL? With ASC-H, could this be HSIL? Cells that raise genuine concern for HSIL should therefore not be placed into ASCUS simply because the findings are limited or not completely diagnostic. Practical microscopic approach and diagnostic pitfalls. When a squamous cell appears questionable, interpretation should follow a consistent sequence. First, identify the cell type and its degree of maturation. Nuclear size and N:/C ratio cannot be interpreted correctly without knowing whether the cell is intermediate, metaplastic, parabasal, or another squamous cell type. Next, determine whether the nucleus is genuinely enlarged relative to an appropriate normal comparator. Then assess the N:/C ratio, nuclear contour, chromatin, and nucleoli. Examine the cytoplasm for perinuclear clearing or other HPV-like changes, but never interpret them independently of the nucleus. Then assess the context. Is there inflammation, repair, atrophy, degeneration, or poor preservation that adequately explains the appearance? If a benign process explains the findings, favor a benign or reactive interpretation. If it does not, determine whether the nuclear abnormalities are sufficiently convincing for LSIL. The practical threshold is, explained by a benign or reactive process, benign. Greater than reactive but insufficient for LSIL, ASCUS. Definite low-grade squamous atypia LSIL. Several shortcuts must be avoided. Nuclear enlargement alone does not establish ASCUS. A perinuclear halo alone does not establish koilocytosis. Binucleation alone does not establish HPV effect. Degenerative hyperchromasia does not automatically indicate dysplasia, and a high N:/C ratio must always be interpreted according to cell maturation. ASCUS should therefore be used for genuine borderline squamous atypia, not simply whenever the cytologist is uncertain. Reporting, HPV, and clinical significance. Under the Bethesda System, the appropriate reporting terminology is atypical squamous cells of undetermined significance ASCUS. This is a cytomorphologic interpretation and should remain separate from HPV status and subsequent clinical management. ASCUS does not mean that HPV infection has been demonstrated. Conversely, a positive high-risk HPV test does not change the cytologic morphology from ASCUS to LSIL. Cytology describes what the cells look like. HPV testing provides additional molecular risk information. Management should also not be inferred from the cytologic category alone. Current management is risk-based and incorporates factors such as HPV status or genotype, age, current and previous screening results, prior colposcopy or treatment, and relevant clinical circumstances. The central diagnostic principle remains morphological. ASCUS should be reported only when squamous atypia genuinely exceeds a benign or reactive interpretation but remains insufficient for a definitive squamous intraepithelial lesion.